Chapter 15 is respiratory emergencies. And obviously, because it's respiratory emergencies, you know that means that we're going to look at some areas of the airway again and do a little review. Patients will often complain about difficulty breathing or dyspnea. And your job is going to be to treat it, recognizing that you may not necessarily be able to figure out why they're having difficulty breathing. As I said, we're going to get right into a review of the anatomy of the respiratory system, remembering the upper versus lower airway, and that you have all of those extra structures that are designed to help you breathe, such as the diaphragm and the chest wall muscles, your accessory muscles, and those nerves that send messages to the muscles to work. Upper airway consisting of your nose and mouth, your jaw, the oral cavity, your naso and oropharynx, and your larynx. There's that picture, and you can see in the top part the upper airway structures. And remember, the epiglottis is that leaf-shaped structure that sits kind of at the back of the oropharynx. And the larynx is where our vocal cord's at. And then you've got the lower airway structures, the trachea, the bronchioles, the bronchi. I should go backwards and say bronchi, and then bronchioles, and then the alveoli sac. Always remember your principal function of your respiratory system in the lungs is that exchange of oxygen and carbon dioxide. The air comes in through your nose and mouth and travels down the trachea. The trachea is protected by the cricoid cartilage. It goes into the bronchi, down into the bronchioles, and then down into the alveoli sac, which is where the actual gas exchange occurs. We have talked about the fact that inspiration is the act of taking a breath in. It is the active phase. And expiration is the act of taking a breath out or releasing your carbon dioxide, and that is the passive phase. A breath in, inspiration, brings in the oxygen. Your breath out gives off the carbon dioxide. This is quite a detailed picture showing you the capillary beds as they sit around the alveoli sac, with the deoxygenated blood coming in and the oxygenated air, your oxygen molecules, going through the alveoli sac into the capillary bed. So those carbon dioxide heavy blood vessels are going to release that back into the alveoli sac and then pick up the oxygen molecules to transport to the body. Gas exchange occurs at the alveoli sac. Your brainstem is going to sense the carbon dioxide levels to regulate your respiratory effort. So when there are more carbon dioxide levels in the blood, it might increase your rate or increase your depth of breathing. All of that controlled at the brainstem. We have a lot of different issues that may cause inappropriate or insufficient oxygenation. Those could be different anatomical issues, they could be diseases, they could be a problem with the actual pulmonary vessels, or we could be looking at traumatic injury. Our goal is that we are going to need to recognize the signs and symptoms of inadequate breathing and difficulty breathing, and you have to recognize the best treatment approaches for those patients based on their signs and symptoms, and understanding when we administer what levels of oxygen for our patients. you've got to keep in mind that when you have a patient who is having difficulty breathing, it is likely because gas exchange is obstructed. There may be damaged alveoli sac from disease or trauma, an obstructed airway. So the air, they're trying to get it in, but it can't get to where it needs to go. Obstructed blood flow to the lungs. So your deoxygenated blood is unable to travel to those capillary beds. Or excessive fluid in the pleural space, in that in your chest cavity, in the lung space, so that you're not able to fill all of the alveoli sac to have proper gas exchange. This is a chart that shows you the signs and symptoms of difficulty breathing. And you can write down chart 15.2. I could read all of these to you, but understand that the signs and symptoms of difficulty breathing are going to look like the signs and symptoms of shock, because improper oxygenation is a cause of shock. It's going to look like potentially the signs and symptoms of chest pain that we'll learn about, because patients who have chest pain often end up having difficulty breathing. So some of them, just to hit some of the highlights here. Symptom, they tell you they have difficulty breathing. Sign, you see them using accessory muscles. You assess that there is an altered mental status. You recognize that the respiratory rate is too fast or too slow, and that the rhythm is irregular. There is unequal expansion of the chest, or the patient is excessively coughing. The skin color temperature is abnormal. Their heart rate is increased. All of those being some of the signs of difficulty or inadequate breathing. They may also complain, so a symptom of chest pain, recognizing again that difficulty breathing is common with cardiopulmonary disease or a cardiac issue too. And if you've ever been in pain, whether it's chest pain or not, you probably recognize that your respiratory effort changes. So breathing deeply causes pain in the chest wall when you get into that cardiopulmonary issue. And that's then going to cause you to drop your respirations or them to become more shallow. Another issue you're going to run into is infection. So there are a couple of different infections that may cause your patient difficulty breathing. So, they can cause obstruction because of mucus or secretions, or they may cause obstruction because of swelling in the airway. But regardless, they're going to cause an inability to appropriately exchange gas and bring in oxygen to the alveoli sac. First one is croup. Croup is recognized by the inflammation and swelling of the pharynx, larynx, and trachea. So they may get air into the mouth and the nose, but basically trying to get it past that into the bronchi is impossible without significant effort. These are the patients who have that seal-like cough. So they might sound like a seal trying to breathe. One of the things that you hear treatment-wise from a doctor is, put them in a humidified room and then stand them in front of your freezer open. So if this is inflammation and swelling, think about what we do for swelling of the ankle. We put ice on it. Well, I can't put ice in the airway like ice cubes, so what I will do is put my patient in front of cold air. And that's more of an at-home remedy because we don't really have the opportunity to do that for our patients in the field. You might have a patient who has epiglottitis. Knowing that itis means that inflammation is occurring, this is inflammation of the epiglottis. Epiglottitis can cause inflammation of that leaf structure, and you see it in the picture there. Well, when that leaf-shaped structure, whose design is to prevent oxygen from going in the esophagus and food from going to the trachea, when that structure swells, it's going to narrow the airway and the food passageway. These patients are going to be drooling because if they can't swallow food, they're not going to be able to swallow their spit either. And we see an increase in this actually in adults now because the main cause was treated with vaccinations, and it's either wearing off or the bacteria, as people are not getting vaccinated, they're becoming more prone to exposure to the bacteria that causes it. Another one is what's called respiratory syncytial virus, and this is RSV. This is very common in very young children, infants and young toddlers. Actually, one of my own kids had RSV. And it's an infection in the lungs and the passageway, so you're going to have a buildup of mucus and secretions. They're going to potentially be dehydrated because it is going to make effort of breathing harder. It's going to make the desire not to take in fluids. We ended up getting at-home nebulizer treatments for our son because they're not going to prescribe a meter dose inhaler for an infant. You are unlikely to be able to do anything for them. And we can't diagnose RSV. I can't diagnose epiglottitis. I can't diagnose croup. What I can understand and recognize is that whole phrase of, presenting as though they have. So, we have to consider this as we look to the treatment for our patients. Another one is bronchiolitis. As I said, itis meaning inflammation. Bronchiolitis is inflammation, easier to have than apparently say. Bronchiolitis is inflammation of the bronchioles. So it's lower airway, and these are inflammation of even more narrow passages in the airway to begin with. So they become inflamed and swell, they'll fill with mucus, and that means they're going to be blocked. And you'll often hear patients who have both RSV and bronchiolitis. Because of the infection in the mucus, there's an even harder time getting air all the way down the airway into the alveoli sac. And then there's pneumonia. Bacterial pneumonia will come on very quickly and be caused by a high fever, or cause a high fever. And viral pneumonia takes time. It tends to be less severe. Viral pneumonia is often what you hear people have when they have walking pneumonia. It can become an issue in patients who are chronically ill. It causes poor oxygenation, and it's an infection, and it obviously is going to impact the respiratory system as well. Pertussis, we talked about this in the last lecture. Pertussis is the whooping cough. This can cause dehydration. It can cause fever. It's going to cause hypoxia and difficulty breathing. And the one to remember about pertussis and any of the bacterial airborne infections is that you've got to use proper PPE. Next is influenza type A. So this is one of the most recent pandemics beyond coronavirus, and that was back in 2009. Influenza type A, you can see the symptoms, signs and symptoms there, the fever, sore throat, cough, muscle aches, headache, fatigue. Can be an underlying cause of pneumonia and dehydration in your patients. But as you can see, those signs and symptoms are going to be common in a lot of these respiratory diseases, so it makes it a little harder to understand. Another one we talked about in the last chapter is tuberculosis, or TB. This is a bacterial infection and is highly contagious in droplet and airborne exposure. So you definitely want to consider the full PPE requirements and infection control procedures. This can cause a patient to have coughing, fatigue, night sweats, and weight loss. Unfortunately, it can remain very inactive for years and then rear its ugly head and cause significant issues for your patient. But as with many of these airborne and droplet diseases, infectious diseases, PPE is going to be very important when you run the call. Another cause of difficulty breathing is the acute pulmonary edema. So acute, anytime we talk about something being acute, it means sudden onset. So sudden onset of a pulmonary edema, so fluid in the pulmonary cavity. This happens as the heart loses its ability to appropriately circulate the blood. And as a result, you're going to have fluid backup into the alveoli and in the lung tissue. You often see this as a result of congestive heart failure. And there's going to be most of the time patients who have long-term chronic heart issues or congestive heart failure, and the pulmonary edema is a sudden onset. So they may be a CHF patient, congestive heart failure patient, for many years, but not have had pulmonary edema until recently. And this is just a picture showing you, and it's the same picture we saw last chapter, the alveoli wall sac and the movement of the blood through the capillaries into the lung tissue. Big one we see a continued increase in is what we call chronic obstructive pulmonary disease, or COPD. This is actually a family of different diseases, and it is the result of often tobacco smoke or long-term damage from inhalation of toxic gases in an industrial setting. It results in the dilation and disruption of the airways and the alveoli, and often creates chronic bronchitis. That is going to be one of the respiratory diseases that falls into the COPD category. So you've got to consider the history of your patient. You know, you don't have to have a history anymore. We've seen the death of people who had lung cancer but never smoked in their life just from the exposure in the environment. Emphysema is the most common type of COPD that you will probably run across or are most familiar with. So patients who are emphysemic, who have an emphysema diagnosis, have lost the elasticity in their alveoli sac. So where you and I have, consider your alveoli sac like a balloon, where you and I can still blow up our balloon and let the air out and blow it up and let the air out, your emphysema patient can blow up their balloon, but it may not have the elasticity to get as big as it needs to. And the alveoli sac have a covering on the inside that if the sides of the alveoli sac, the inside, happen to touch, they may stick together and that alveoli sac may never expand again. So you've got to be concerned about your patient losing the pressure in their lungs and it not allowing the alveoli sac to stay open. So what ends up happening in your COPD patients is a lot of trapped air. So you can see in that second picture, there is a buildup of inflammation or an infection or mucus there along the lining of the bronchiole. And in the third picture, as it gets worse, and that infection and that obstruction collapses and does a full blockage, then you've got trapped air in the alveoli sac that can't go anywhere. So COPD patients who have edema, pulmonary edema, are going to have a very wet sounding lung because they have fluid in their lungs. It's basically a dry drowning where they haven't been in any water, but the fluid buildup in their lungs is causing respiratory distress. If they have COPD, they're going to have a dry sound because it's not fluid that is causing the problem, it is air. You're going to have patients who call 911 because of difficulty breathing, result of asthma or anaphylaxis, hopefully not hay fever, but you never know. And you may never know the cause of the allergic reaction in your patient or what is causing them to have an asthmatic incident. But what you are going to do is treat it, knowing that asthma is spasms in the smaller air passages and the bronchioles. So when you spasm your smaller air passage, you are actually going to make it smaller, and it's an uncontrolled spasm. So it's not something that is easily fixed with just thinking, oh, I'm going to calm down, and the spasms will calm down. And that spasm, as it narrows that airway, is making it harder for the air to move in. Know that no one is immune to being an asthmatic, whether they have a prescribed inhaler, whether it is a chronic condition or a sudden onset condition. Asthma, because it is a lower respiratory blockage, will cause wheezing, and you'll hear it potentially even when you walk into the room. So if you walk into a house or into a facility, a business, for an asthma attack, and you hear, you're probably gonna have somebody who's having significant issues. And there are some causes that are pretty common, some that are easy to control. And then sometimes, like I said, you can just be standing there and have somebody whose airway passages spasm and cause an asthma attack. Hay fever causes cold-like symptoms, so you'll get a lot of congestion, fever, respiratory distress just from the cloggage in the mucus. And they're often caused by things like pollen or dust mites, pet dander, that type of stuff. And it's more seasonal. And then your anaphylactic reaction, as we talked about last chapter, that is a life-threatening an emergent allergic reaction, can cause total obstruction of the airway if left untreated, and can often do so very quickly. We're going to treat that with a drug, and all of them oxygen. We may find a patient who has a spontaneous pneumothorax, and this is not as common as like an allergic reaction. And a spontaneous pneumothorax basically means your patient is walking down the street and coughs hard or laughs hard or stretches the wrong way and causes trauma to the lung tissue, which then creates a pneumothorax. Spontaneous means all of a sudden. So it's possible that this is the result of diseased lung tissue or some other medical condition. But the spontaneous pneumothorax is then going to cause there to be a hole in the damaged lung. And what this picture shows you is what happens in the pleural cavity and in the space between the lung and the chest wall. And when that lung opens up and releases air into the chest cavity, it's going to then collapse and cause a decrease in oxygenation in your patient. When you go to listen to breath sounds, you'll likely not hear any on that side because there is no air moving in and out. When they take a breath in, it is going to move out of the hole that was created by that spontaneous pneumothorax.